All right, hello everybody. My name is Amalia Weber. I'm the program specialist here at Rochester Hills Public Library, and I'd like to welcome you to this evening's program, Advancements in Stroke Care, presented by Ascension Providence Rochester Hospital. Before we get started, I'd like to take care of a few housekeeping details. Firstly, tonight's program will be recorded and available to view about 1 week from tonight on our YouTube page and on the RHPL website shortly after. We ask the audience members please silence or turn off their cell phones before we begin in order to avoid any disturbances during the presentation. Our next program is a concert, The Magnificent Seven, which will be an in-person event on Sunday, May 22nd at 2 p.m. You can sign up for that at calendar.rhpl.org. And now, without further ado, please welcome our presenter, Dr. Whapham.
Thank you. John is fine. We're having a small, intimate venue tonight, apparently, so I want to introduce myself. I'm John. You are?
Pedro.
Pedro.
Tom.
Tom? Yeah. Also Tom, my father, and my mother, who are bored in Rochester tonight, so they're hanging out with us, if that's okay with you two gentlemen. So we're going to talk a little bit tonight about kind of new developments in stroke, and there's been some confusion as to whether we have a neuro-interventional stroke program across town at Crittenden. What I know is Crittenden, now Ascension Providence Rochester, we do. It's been in evolution for about a year here. We'll talk about kind of what that means, and a little bit tonight of the history of stroke and kind of where we've come with stroke over the last 25 years, and I'll go through a little of that with you. As we go through some case examples at the end as well, and I'll try to show you some real life examples of large vessel cases. And that's what I do for a living. I'm kind of a head and neck plumber. I'll talk to you a little bit about my background originally. So tonight's talk is going to be entitled Neurointerventional Surgery and Stroke. So we'll talk about those areas, and I'll touch on a couple of topics kind of that are accessories to those, including telemedicine and stroke infrastructure, which is a big topic in America right now. It's one of the issues we're struggling with because we've put a lot of energy and inertia into the science of stroke and thrombectomy and medical therapy of stroke, but yet we've got 25-year lagging infrastructure to process stroke patients. If you've had an example where you've had a stroke and had infrastructure fail you, it's a real issue. It's unlike that for trauma and for cardiac arrest in America, but it shouldn't be. And that's a failing of the American medical system right now with stroke. And so we'll talk about some of those hurdles. Tonight's talk is going to be a little weird. We're going to treat it like a Hollywood movie. We're going to start in the past. We're going to jump to present, and then I'm going to fill you in on the story in between like a bad movie. And we're going to jump around a little bit, but it'll be entertaining. So the year is 1982. That's me at 10 years old in the middle of Rochester Hills, Michigan. So I'm from this area. I grew up in Rochester, literally on this street, and went to school down the street. Grew up here many, many years ago. And we'll talk a little bit tonight about infrastructure. We'll talk about time. We'll talk about the push with stroke and the urgency of it. We'll talk a little bit about some of the failings of it. We'll talk about medical therapy. I'm going to even touch on some anatomy. It'll be a little over the top maybe if you're not clinical and in the specialties, but it's important because I tell people I'm kind of a glorified head and neck plumber, and if you know the plumbing, it makes common sense what we're doing and why it's so time sensitive, so we'll talk about some of that tonight as well. You can tell the picture is dated if you look carefully at the clues. I always stop people and say, well, you know, glass 20-ounce Pepsi bottles tells you what year and decade we're in, right? Leather Lions gym bag, because there wasn't any vinyl and plastic and nylon back then. It's an actual quote from the FedEx people. We live and die by time, and we must not commit the sin of turning our back on time. For a lot of years in stroke, we did that. We jumped forward to taking it a little more seriously, and now with all the economic setback and hardships with COVID, we've taken our eyes off the ball yet again with stroke and some of the time elements, which I'm troubled by. And we'll talk about some of that. So I'm going to jump now to 2015. The year is 2015. I'm in a conference in Nashville, Tennessee. And at that point in Nashville, Tennessee, all of a sudden, after about maybe 15 years to 20 years of stroke medicine going on, all of a sudden an article comes out in the New England Journal of Medicine that afternoon. And it sends shockwaves through the stroke industry and interventional industry. Because for the first time, mechanical thrombectomy is now the gold standard for acute stroke and large vessel stroke and all the implications and ramifications that has for stroke treatment. Prior to this, you got to remember, we'll touch on this, prior to 1995 or 96, there was not even a medical therapy for stroke. You just had a stroke, that was it. I can remember being a medical student and a grad student and just watching people have life-ending strokes in front of me, you know, while doctors and residents just categorized them and wrote notes and stared at the people. It was really shocking. You know, after that era, there was just this lag to people actually wanting to use this clot-busting drug we had called TPA, which is now obviously a standard of care, but they didn't even want to use it after it was approved by the FDA. And it's not really until 2015 that an article comes out that validates all the stroke mechanical therapy that people were doing behind the scenes quietly from about the early 90s into 2015. And that article got published because of the work of a lot of people around the country. I won't say a lot because when I originally started in this business, you could fit all of the interventional stroke people in the country into like a Starbucks lobby at an airport. And we used to go to conferences and everybody knew everybody in the country, just a handful, a dozen or more of us. And now there are 400 or 500 people and a couple, 10, 20, in every city. But it didn't used to be that way. And the combined work of a lot of these people over 15 years made for this, but I can't emphasize to you enough what a big pivotal difference that little study made. As prior to this era, there was nothing that validated stroke thrombectomy. Those of us that would do it, I can remember getting escorted out of hospitals by security for witchcraft and heresy, and by the American Academy of Neurology, and department chairs, not allowing people to do thrombectomy in their departments because there was no literature for this stuff until 2015. So this was a, free at last kind of moment for a lot of people that do stroke care. 21, 22, weird couple of years. I think everybody would agree. It's been a wild time the last 2 years, particularly in medicine, also obviously in business and finance and a lot of other commercial areas of the country, from everything from racial stuff, gender confusion, to now we're finding out there's been 400 alien visits that nobody told us about. This guy, don't even get me started. That's like a 2-hour talk right there. The conundrum over what this really means to all of us on a daily basis and where that's headed, to even this scene, which is a real scene where Spider-Man visited the Pope last year. I don't know if any of you caught that. Strange year, one I hope is not duplicated in 2022. So I'm the medical director for the new neurointerventional program over at Crittenden or Ascension Providence Rochester. I'm a neurologist and psychiatrist by original training. I know that's weird. But that was our original background before this science existed. When I was a resident, my field didn't even exist, which is weird to say as a doctor. So I went through a traditional neurology and psychiatry residency after graduate school in bench research in neuroscience and neurochemistry down at Wayne State, and did fellowships in stroke medicine and neurointensive care, which is my sort of parent discipline, and then did neurosurgery fellowships to arrive at the business of the catheter-based therapy that I do today. Back then, there was no roadmap, really for any of this. We had to make it up, so we would jump between disciplines to get the background we needed to do this kind of work smartly. And so I had the program over there along with 2 PAs that are not here tonight, Romario and Simon, that help guide patients through the very intricate process that you're going to see us talk about a little bit tonight. And so we're going to talk about, the business of neurointervention and medical stroke and cover some of those things. Usually with me tonight is a lady named Lindsay Z. She heads up Stryker's division that's housed right here in Rochester and provides a lot of the stroke actual devices and catheters that we use in acute stroke therapy. Normally she's here with me, has actual devices for you to play with and touch that we use up in the head. Would have liked that tonight, but she was babysitting tonight and didn't have a nanny to babysit her kid and couldn't come. Normally I would pass around an actual stroke device that we use up in the head to give you an idea of what it feels like and what texture it has and how we grab clots in the head with it. But I'll show you some photos that I threw in there as well, which will show you the devices in high magnification. You'll get the same idea. I don't really have any financial disclosures. Unfortunately, I have been in the industry for 20, 25 years, but never taken advantage of making money in the industry when I should have. And there's a lot of devices today that have my handprints and measurements on them that we, as trainees, were asked by these companies like Stryker and Medtronic to, how would you put the hand grip on this device if you had to put it. And so there's a lot of devices that I open packages and use today that have my handprint on them from when I was a fellow that we weren't paid for at the time or any of that stuff. I don't have any financial interest in any of the companies that make devices that you're going to see in this talk as well. The only financial tie I've ever had my whole 25-year career is with this company called TechnoAid. They don't pay me, but they make the lead suits that we wear for protection in the cases. And way back when we started this business, it was a big departure in the amount of fluoroscopy and x-ray that you take doing one of these cases. Nobody had really done live fluoro this long And back when the devices weren't as good as they are today, the cases would go 5, 6, 10 hours with live x-ray beating on you. And that was before tables by law had skirting and lead skirting on the bottom of the cardiac tables that we would use. So you would come home from a day at work and have sunburns on your leg from the x-ray dosage and red peeling skin and stuff. And I've known several people that have had breast cancer and parotid cancer. And I have a cataract myself from when I didn't wear glasses as a fellow in my left eye. So when I got my first big job at a university after training, I started doing the math of like, this stupid. Why doesn't anybody have anything? That's one of the items where I should have capitalized back then, but I didn't. I researched and I said, somebody should make like a suit where you don't have to worry about the dosage because you're in it protected. So I drew it on a napkin in the Loyola University Stritch School of Medicine cafeteria and started sending it by email to people. And I found a company in Tennessee that would make me kind of an Iron Man suit that had arms, legs, joints, helmet, everything. And they made it. And ever since then, every year or two when my suit wears out, they make me a new suit. But if you research me, I'm on their website wearing pictures from when I had dark hair like 15 years ago, wearing the suit. So this is the only real financial, I don't get paid by them, but I get a new suit every couple of years for my troubles out of them. And they make really nice stuff. If you ever need a lead suit, these are the people you want to talk to. Future topics, if anybody in Rochester is interested, that I've done in the past for resident education or just anatomy, some of the anesthesia concerns in these cases, some of the screening images we use, which we'll talk about tonight, that we use to screen and pick the patients for intervention, some of the intracranial pressure and swelling management concerns, some real ICU case examples of real patients, some aneurysm talks that I've done in the past to look specifically at a subsegment of stroke, ruptured intracranial aneurysms, which are types of strokes, telemedicine, which I spent a good share of my career involved in, mechanisms of air transport for these patients, given that it's a very time-sensitive process, which I've devoted a lot of my career to as well, and also arteriovenous malformations, which I used to do quite a lot of at the university in an era when nobody really did a lot of those. So these are all future topics that people have had interest in over the last couple of years. Strokes by the numbers in North America. So it's estimated there are about 7 million stroke survivors living in the United States right now. About 1 in 6 people will have a stroke in their lifetime. That's a lot when you think about that number. 4 out of 5 families each year are affected somehow, either economically or somewhere by a relative or somebody with a stroke. 73% of stroke, and this is an important slide, and we have several of them sitting here today. 73% of stroke victims are going to survive. The question is, how do they survive? Do they survive sitting in the room, able to attend a stroke talk, or do they go to a nursing home with a trach and a PAG tube and, need total nursing home care? And I hate to tell you, but the difference between that scenario and the latter scenario can be minutes and can be recognition and identification. And so we'll talk about some of that tonight. So it's estimated about every minute, 2 million neurons are lost that are never coming back when there's an occlusion of a vessel and a stroke. And so this is a big number when you think about all the fooling around that happens and all the touch points that have to happen that we're going to touch on in a minute in stroke. A minute goes by awfully quick. And you'd be surprised and impressed at how much time gets blown in the course of natural entropy in medicine when it could make a difference between somebody going home and somebody living out the rest of their days in a nursing home with full care. And I guess I would conjecture, and I'm not particularly political, and there's some political slides in here just to be funny. I don't really have a tack one way or the other. I think American medicine right now is a tragedy, no matter who's president. But I think this is a big enough number, and some of our inequities in the logistics of stroke are a big enough emergency, and medicine itself economically is a big enough emergency where I wish this were on the table like Ukraine and a lot of other things going on in the world right now in North America, because this time matters. This is our air crew here in the hospital as well. We have a nice pad that's out in front of the hospital. If you haven't been there by the emergency room, it's moved. When I was a kid, it's out in front of the hospital right by the street and Walton Boulevard. Now it's tucked nicely by the ER, which makes a really seamless transition from ground. Aircraft lands right wheeled in the door of the hospital into the cath lab. This is Romario, one of our neurosurgery PAs, ER doctor, some flight paramedics, and our stroke coordinator, Amanda and Michelle. And we are looking to kind of garner a little more of this air traffic into the area. There are people stranded out in the thumb part of Michigan that really don't have access to a lot that we could be helping here. We need to do a better job of getting these people here and moving them in an efficient time. When I talk about stroke in America, sadly, despite everything I'm going to talk to you about the advancements, the logistics on a day-to-day basis of stroke look like this. It's still this. It's herding cats. It's trying to get 15 different disciplines, all who have differential buy-in to the time involved in it to do the right things and fire off in concert. It's a cluster, and I'm not going to apologize for saying that. It's still very complicated and like herding cats to get a stroke through the process from field into the hospital, imaged, treated, on the table, and out of the ICU. It's complex, a lot of working parts. Stroke in America particularly, and there's Joe Biden, I think, having a small TIA. That's an actual video. There's a definite stroke belt in America. I worked down in the southeastern United States for 4 or 5 years. There's no question there is a geographic predominance down there. Some of it is educational, some of it's primary care related, some of it's dietary, frankly. Some of it's, poor care of hypertension and diabetes. It's kind of cultural. Some of it is just, lifestyle related and other things, but there's definitely a trend in this part of the country to the incidence of stroke. If you notice the dark purple, we get some of that up in Michigan. We have some of that, whatever that same, gemisch is up in southeastern Michigan as well. We're getting some of this purple out in our area as well here. So some of the demographics and logistics translate from the deep southeast to the part of Michigan that we live in as well. And again, it's a complex problem. That's what makes stroke so hard to treat effectively. Tons of people in the mix, tons of touch points. The more touch points in process, the more complex the infrastructure needed, the more multifactorial individuals involved, the more complex it is to execute. So about every 40 seconds there's a stroke. It's the number one cause of adult disability other than trauma in America. 700,000 to 800,000 strokes a year in America. Lost disability-wise, they estimate in the $50 billion range from lost wages and income and that sort of stuff. So this is a big ticket problem. It used to be the third leading cause of death in America behind trauma, MI, and cancer, and it fell for a while to fourth or fifth. We had made progress, and then COVID hit, and it's back up to like the fourth leading cause of death in America because of all the coagulatory complications of COVID. And I'll show you some examples of that. Stroke, and I usually spend a ton of time talking to EMS, and when I got here, I talked to EMS in Rochester and around the surrounding areas about the logistics being a really huge concern. Now that we've got the medicine of stroke solved and a lot of the interventional tools that we have today, the burden is on the front line. It's on identifying people, moving them, the logistics of getting them into the hospital to treatment. So now EMS and the actual transportation and information sharing becomes the biggest hurdle. And for years, we bet on this not being an urgent issue like stroke, like for heart attack or trauma. But then the study came out in 2015, and all of a sudden America got caught with its pants down and 25-year delinquent infrastructure for stroke, and now we're still catching up. And so a lot of this hasn't been dealt with. How do we talk to folks in the field? How do we train folks in the field to identify the stroke and the severity and get the person to the right hospital and the right kind of discipline at the right kinds of hospitals? We're not really doing this right yet in North America, particularly Michigan. Michigan's still driving people past catheter-capable hospitals to drive them extra distance to hospitals that have some different buy-in with EMS. So every day I watch patients get driven to Troy Beaumont where they don't have stroke interventional cath lab, so they can sit and wait for a bed to be called in at Royal Oak Beaumont to get their interventional procedure. You can imagine the delay when that happens, but they literally pass Crittenden on the way there. So there's a lot of work to be done still on this. This is an example of one of these retrievers being deployed in a stroke clot. We're going to talk about this further. We'll also talk about types of stroke. So about 80% of stroke, 85% of stroke is what we call ischemic, where there's a clot in a blood vessel, so oxygen's not getting to brain tissue. The other 15% is hemorrhagic, where there's a pop or an aneurysm in a blood vessel, and the blood leaks out, and that's also a kind of subsegment of stroke. And this is the kind with a plug in the vessel. And as you know, the front line for this since the mid-90s has been this clot busting agent, TPA, which we'll talk about a little in a minute. Over the last 15 or 20 years, we have thrown everything but the kitchen sink, quite literally, at the infrastructural problem with stroke. And I've been involved in a lot of that the last 2 decades. And here are some examples throughout my travels over the last 2 decades of all the things we have thrown at the field side of stroke. And that is figuring out how do we identify people in the field, how do we get the doctor directly to them and not wait for them to come to the hospital, how do we see them, how do we examine them, how do we even treat them in the field before they even get to the emergency room. Believe it or not, we have and we are fooling with all that type of infrastructure. And here are some examples. So here's an example of one of the first telemedical robots used in the country to see patients in the hospital with a remote physician seeing them in real life in person. And here's an example of a robot that was used in the early days to do this at Loyola. And this was so novel back in 2010 that it put me on the front page of the New York Times for doing it, which was, I didn't really think anything of it at the time. It was just a tool to see patients in real time and cut. It was like, you know, today you'd think nothing of FaceTiming your wife or your grandmother, but back then it was a big novel thing. And it was so novel, the New York Times picked this up. Went on to work in Toledo for a part of my career, and we actually decided to put mobile CAT scanners in ambulances. It's a big rural area in northern Ohio, and so the distance in could be hours to get somebody from rural quadrants of northern Ohio. And if we could look at them in the field, do a rudimentary CAT scan, transmit it on a mobile device to the doctor and drip the TPA in the ambulance, we could cut 2 hours, we found, out of their time to get TPA. So we would do that in northern Ohio with a mobile CAT scan and dripping the tissue plasminogen activator in the rig while the doctor could see them mobily on a cell phone apparatus. I extended this to air over northern Ohio and southern Michigan in helicopters for the first time. And so we demonstrated that you could see patients in flight and actually treat them in flight with good ability if you needed to. I treated one of the first people in the country. Guy was golfing in Traverse City, and I was in Chicago at the time. He dropped golfing, and I treated him on a helicopter flying over Lake Michigan to land in Loyola. At the time, we were the only hospital that could land aircraft because the city doesn't allow you to land aircraft. So they diverted him to me out in the west side of the city where you could land aircraft. And I treated the first guy remotely on a helicopter that way. This is an example of down in southern Alabama. We had trouble when I worked down in the deep south with weather. And if you've ever been down to the Gulf area, beautiful, nice people, but a lot of the year it's just crappy weather. The late summer, early fall is hurricane season. They get daily wind and rain and weather that's so episodic and volatile that civilian medical aircraft cannot fly. And so we were finding that we were grounded 40-50% of the month. So we had to look for a solution at a big, I was involved in a program down there where I treated about 1 million person population. And I was the only guy that did this work down there for 3 states at the time. So huge population catchment area, hard to get them to me. And so what we did is we harnessed the 110th Aviation Regiment at Fort Rucker in Alabama, and we used Black Hawk helicopter service there with 110th in order to triangulate between patients and fly them in any weather. They fly on night vision and infrared and conditions that you can't imagine, and they love it. In fact, because every year they're on the closure list for bases, so they like the experience. They love doing it. And these guys they'll fly in anything because it's real life training for them because they're getting shipped off somewhere to Afghanistan next. And so the nurses and paramedics and stuff on these flights love it because it's a good experience. So let's talk about mechanisms of medical stroke. When we talk about stroke mechanisms, we know today actually better than we did even 10 years ago that maybe 30% of them or more are caused by heart-related issues. Yes, there's a good segment of them that are caused by just plaque and cholesterol and the large arteries of the head and neck like you would expect, just like the heart vessels. But we now know that the heart is a big generator of clots and prothrombotic states that then get ejected like a pinball game up into the head. And that's a big issue right now, and we didn't know this. We didn't have the surveillance and some of the, Fitbits and watches and remote implantable devices that we have today to watch for AFib. And the problem we have is it's like a car that makes the noise, only when you drive it home from the dealership, and people didn't know they were an AFib. They would get treated for a stroke, didn't know why they had it, everything else was normal. They'd go home and be an AFib sporadically for the next 2 months and have another stroke because nobody caught it on the one echocardiogram or EKG they had at one point in time. Now, with telemetry and monitoring and watches and all this electronic wearable device stuff, you can see this stuff in real time, chart it, identify it, even have it alert you that you're having an event. So we're catching up about 30% of these sort of clandestine strokes are cardioembolic. This has been a big deal because there's devices now and anticoagulation to help take that risk down to almost zero if you can identify this going on in people. So this has been a big deal. The other deal, and a gentleman and I were talking about it earlier, is there's now been a lot of work at this secondary injury. Once you plug up a vessel and actually injure brain and have a stroke, there's all sorts of secondary inflammatory mediators that get lit off. And those can't be stopped. Once they're started, it's like a roller coaster rolling downhill that injures other parts of the brain. And so now a lot of biochemists are targeting this secondary activation of inflammatory cytokines in a revolution that's going on, looking at inflammatory disease to see can we give somebody a magic bullet, if you will, of an infusion that after they do have an event and you open all the vessels that will stop and put the brakes on this secondary inflammatory process that causes a huge amount of damage with stroke. So again, we're going to talk about anatomy in a minute, but keep these two things in mind. Calculating stroke deficit. So this is where we struggle with EMS. These are not doctors. These are not nurses many times. And we talk in a language with stroke like the Cincinnati Stroke Scale and the National Institute of Health Scale and all these clinical designations for disability with stroke. And we use a 30-point, 40-point scale or a 42-point scale. And we're asking people to be able to do this math that takes 40 minutes, to identify what severity of stroke and then figure out what that means as far as where to transport it to what kind of hospital. It's a disaster. This is a vestige of old neurology, and it's still in use, but it's stupid because it really doesn't help people in a pinch identify what's serious, what's not as serious, what's high likelihood to be a large vessel plugged up, and what's not. And so, although this is great to learn if you're a neurology resident or going into stroke medicine or maybe an ER doctor even, in practical terms to EMS, this is gibberish. It means nothing. They don't know what any of this means. They don't know how to communicate in this. They wouldn't have any idea how to do this. You're asking them to be a doctor, and they're not. And they have a hard time with this stuff. So, this is my quick bedside exam. When I go see a patient at a bedside, I think of this Billy Squire song from the 70s, and it plays in my head. And this is really all you need to do. Can the patient put, like the lyrics say, can the patient follow a command? Can they put their right hand out? Can they give you a firm handshake? Can they talk to you? Can they do the lyrics essentially of this Billy Squire song called The Stroke? And it's goofy, but it's how I teach residents to remember the basic exam at the bedside in 30 seconds to tell you whether somebody's aphasic. Can they talk? Can they follow commands? Can they move both arms and legs? Are they numb on one whole side of the body? Do they have facial asymmetry? That's all you need to know. And in 30 seconds, I know what vessel's plugged up, and I can tell you with certainty that it's large vessel or it's not 99% of the time. And so we need to be doing more of this with EMS and identifying hemiplegia and hemisensory deficits and language disability and field defects and stuff where people are cocked over and only looking to one side and neglecting the other side. These are high yield things we can be teaching people that would really change how we view stroke in the field. And I'll talk about this briefly. And the one thing, despite all the literature for the last 25 years, and it is mountains and mountains and mountains of literature that look at which dose of aspirin is in vogue this year, or which cholesterol medicine is cool this year, all of which is great and reduces risk factor, but is meaningless for acute stroke, obviously. The only thing that has ever been borne out in all the sum total of all the literature for stroke is that, speed. It's the same as the trauma literature after Vietnam bore out. It's the same as cardiac literature bears out. Speed of identification, speed to the right facility, and speed of intervention of the problem, whether it be medical or whether it be surgical or a combination of both, is the only thing that is predictive of outcome. There's a little bit of outcome prediction with rehab, and we'll talk about that briefly, but sooner to rehab, the better the quality of regaining function you're going to get. And we know this for a fact now with several studies, but this is a fact. Speed. And people have this belief now, because the literature has changed to allow us to look at people up to 24 hours for stroke intervention, that we now have all this time. We don't. That doesn't change the physiology. The fact that we are able to grab people and sometimes even late in the game do something good for somebody in a cath lab doesn't mean you have 5 hours to call us. And people have this mistaken belief in ERs and in medicine that now we've got all this time. It doesn't matter if we have to hurry and we don't have staff that day to hurry. It does matter. Every minute. Remember, 2 million neurons a minute. Tick-tock, clock's running. 2 million neurons a minute. There isn't a second place prize. Second place prize for this might be dead. Second place prize maybe doesn't eat for the rest of his life, or can't walk, or is in a nursing home, is second and third place. There is no second place. One of the things I talk about with EMS is this slide. There's all this anxiety tied up in stroke medicine, right? Other than if you do it for a living every day and you're at peace with it and you're used to it, it is anxiety provoking as hell to everybody else involved in the process. ERs hate it, nurses in the hospital hate it, anesthesia hates it, everybody hates it because it's stressful. All of a sudden you need an ICU bed out of nowhere. All of a sudden you need to go to a cath lab. All of a sudden at 2 a.m. on a Saturday night you need anesthesia. All of a sudden you need 5 sets of images and somebody to read them. It's a drag for everybody, except for the patient is involved. And I tell people that there's a reason we work fast and we do all the things we do. And if people can sort of, if you've seen this movie, Ricky Bobby, which is a favorite, there's a lot of life lessons in that movie, but if you can drive with the cougar in the car, as he does in the movie, and take the anxiety out of the picture and do what's the right physiology for the patient, you can do a ton in the field actually for stroke patients to extend the windows that they can survive and have less disability. And I enumerate for EMS these things. One is blood pressure control. There is math to the level of cerebral blood flow and oxygenation of the brain. There's a curve called the Cerebral Perfusion threshold curve. And your brain is designed with a little slop in how much blood pressure and oxygen it can see. And it's designed to have the vessels auto-regulate and contract and dilate such that if I don't have a great head of pressure getting up in my head to deliver oxygen, the brain vessels will responsively shrink down and get tight and make the pressure go up higher. And when there's too much pressure in the head, they'll relax automatically to allow the pressure not to be so excessive that you die of a rupture. But there's a special curve that we're all built with, and the minute you fall off that auto-regulatory curve, game's over. And you're either going to have a stroke or you're going to bleed. And if you hijack the sweet spot of physiology, which is about 140 to 160 based on the literature, you can keep people's survivability longer. In other words, we're born with interdigitating blood vessels on either side that cross water hemispheres, and people have a collateral cerebral vascular reserve. And it's sort of this analogy. It's like squeezes in the bottom of a tube of toothpaste. If you hydrate them and volume expand them and squeeze on that blood pressure and get them up above 140, you'll actually take advantage of watershed blood flow and oxygenation, and brain tissue can hang out longer without the piece of plumbing that went to it by getting it elsewhere, contralaterally. So this is a game we play with physiology to do that. We aren't afraid to treat blood sugar. We know from the literature that optimally you want euglycemia or normal blood sugar in people. If you're too low or too high, it does brain damage. And so we tell EMS to treat these. We put IVs in them. We boatload them with fluids to do this, to squeeze that bodily tube of toothpaste and get their volume up. Many people, when they have a stroke, are found down. They're down for an hour, 2 hours, sometimes a day. Their volume depleted. So their blood pressure is 80, 90. Their brain is not getting good head of steam and oxygen and pressure. One of the most life-saving things you can do when you find a patient like that is hydrate them. It sounds stupid, but bag of saline can save, I've seen it save people's lives. We try to get as much history as we can in the field to know what medicines are on, if they're on any blood thinners that need to get reversed, if they have any cardiac history, what their code status is, their wants, wishes, dislikes. I've worked on people as old as 101 years old, but sometimes we get somebody at 90 that says, I don't want anything, done, and it's good to know that before you go do a procedure on them and intubate them, and they didn't want that. And we also try to control blood pressure with people with agents that don't dilate the blood vessels. I don't know why, but EMS all around the country don't understand the physiology. So the first thing they do with somebody that has a little bit of high blood pressure is they give them nitroglycerin, which dilates all the blood vessels. And what do you think their pressure does? It bottoms out. And now you've just worsened the stroke. And it's a vasodilatory agent. It's a worst agent you can use to control blood pressure in stroke, but they use it all the time. Because why? It's cheap, it's easy, and it's available on the rigs, and that's so they use it. I don't get into this much except with the residents. There's all sorts of scales like this to have people look at pictures and tell you what they see, to interpret their language ability. Most of the time, we can do this at a glance at the bedside by going like this and saying, what's this? And if they can tell you that's a watch, a wristwatch, and what do you do with it? Or you tell time with it. You've just answered 1,000 questions on their exam by their ability to say that, as far as their cognition and their language and naming ability and stuff, instead of making them go through these. And we'll talk a little bit about localization. I won't get into the details, but one of the tricks is correlating the exam with the piece of plumbing that's occluded in the patch of brain that's not getting blood flow. So this is the overall map of where I go when we work. So going from the shoulders up, I work from the neck up, basically. So you got two arteries, you touch the side of your neck, you feel the carotid artery pulsing in your neck. That shoots up your neck, delivers blood to either side of the brain. It bifurcates about the jawline there into an external branch that goes out, does your scalp and your skin of your head and stuff, and another branch that goes through a hole in the bottom of your skull right there and becomes the supply to the left side of the brain, and you've got a duplicate goes to the right side of the brain. As you notice in the picture, they're tied together, right? There's two little connecting runs, like a goalpost of a football goal, that connect the carotid circulations as they terminate on each side, called the anterior communicating artery. And it does just what it says it does. It ties the two carotid circulations in the head together in this ring called the circle of Willis. That ring is also tied to the circulation that goes up through the vertebral column in the neck. This gives blood supply to the vital brain stem and back part of the brain, the older part of the brain. These two, primitive circulation and our newer carotid circulation, are tied all together in this ring. And it's a survival, evolutionary adaptive survival advantage that allows us to lose a vessel somewhere and shunt blood if the right conditions are met physiologically from elsewhere. And so this is life for a lot of people with large vessel occlusions, the way their plumbing is. And we hijack that. It's the main thing we hijack in stroke to get to where we need to get. But this is how we actually get up with catheters, and I'll show you a little of that to get to work in the head. We actually go all the way up with catheters up in there to work. correlating the artery with the deficit in patients. I won't belabor this, and I don't expect people are going to clinically follow a lot of this, but basics. If you can't talk, you've interrupted blood supply to the left frontal and left temporal part of your brain. That's where 90% of our language comes from in most individuals. There are exceptions where people are right brain for language when they're left-handed, but it's a very small percentage of people. So if you can't talk or you can't understand speech, you have either a frontal ischemia or a parietal ischemia going on the left side, left hemisphere typically. And that correlates to the middle cerebral artery typically. If you can't move your right side, where do you expect the deficit's going to be? Left-sided plumbing, right? If you can't move your left side, usually you've got an interruption in flow to the right side. Cross circulation, in other words, your right side controls your left, controls your right brain, but that gives you left-sided motor and sensory. Your left-sided circulation controls left brain, makes you have function on your right arm and leg. And so these are the maps, and these are the two things laid over. That's that same plumbing map now laid over the quadrant map of where those arteries serve in axial cuts of the brain. So again, the carotids in the neck, they go up, they form this circulation in the brain. This is the right side, this is the left side. We have these middle cerebral arteries that go out to the hemispheres, that's the yellow quadrant. We have these anterior cerebral arteries, they go up like this and they do the frontal lobes and some of the frontal circulation. They are colored red in this cross-sectional cookie cutter slice of the brain. And then we have these arteries called the posterior cerebral arteries that peel off, and they do the back occipital part of the visual cortex of the brain. So if I take that picture and I show you somebody can't talk, you expect probably they're interrupting left. Again, this is the left, this is the right. They're reversed in the picture when you're looking at them. So they're interrupting the middle cerebral territory and can't get right arm and leg function or language from this. If somebody can't move their legs, the legs are controlled mostly by the anterior cerebral circulation or this red quadrant. So when somebody has left-sided anterior cerebral artery block, they usually can't move their right leg and vice versa. And when somebody can't see on one side, they have an interruption usually in this occipital visual cortex area, the green. Again, you don't have to memorize that, just gives you a gross idea when we look at somebody's exam, what we're already thinking as far as which vessel should I be thinking about and where is not getting blood. And you're going to see this in some of the functional imaging examples. Again, zones and watershed areas, these zones aren't exactly like a coloring book. They overlap like this. And so you get washout area where an anterior cerebral artery can be watered by a middle cerebral artery, or vice versa. Middle cerebral artery, if it's occluded down here, can get blood flow from an anterior cerebral artery washing over if you take advantage of that volume and blood pressure like we talked about. But again, these are the quadrants. This is this left middle cerebral area, frontal area or anterior cerebral, colored yellow here, and this occipital part and temporal part blue distribution, posterior cerebral artery. Again, this is cutting this way now, front ways or coronal. Same things, yellow, middle cerebral, blue, anterior cerebral, and this pinkish or red posterior cerebral area. And you can see the watershed zones where they overlap. And you see some of the little perforating branches that go off as they go to those different quadrants and how some of the areas that they overlap in, just to give you a flavor for the zones there. And again, same thing. Same colors laid out. Here's an example of how the anatomy can be altered. Some people don't have a complete circle of Willis. They're only connected to one side and they're isolated without a connection on one side. And these people are in a lot of trouble if they occlude sometimes this vessel because they're not getting any collateral circulation through that circle of Willis across. And we run into these people every once in a while. They have zero time. Usually shows over in minutes because they don't have any collateral reserve if somebody's not taking advantage of the hydration and volume. They don't hang out as long because they're not connected to this circle of Willis, and maybe 20% of the population's plumbed that way, and so you can't count on them getting collateral flow because of their plumbing being aberrant like this. But this is normal, variant normal. 20% of the population is set up where they are one-sided like that. And we see that. This is a problem area. There's a stroke right now. This is a problem area. The posterior circulation. And so the posterior circulation is a problem area because it goes to our brainstem and really primitive areas of the brain. It's an area that doesn't survive interruption very well without big deficits. And it's an area of the brain that is hard to get to. It's two small wispy arteries that sort of dive up the cervical spine. They coalesce into one artery called the basilar artery there that you see bathes the brainstem and cerebellum and some areas that are more primitive in the brain. And this is an area that doesn't have as drastic a symptomatology. These are patients that just get sleepy or confused and have generalized symptoms. They're not necessarily hemiplegic. They're not necessarily unable to talk. They're sometimes drowsy, a lot of times vertiginous, dizzy, throwing up, just violently nauseous, headaches out of nowhere, and they get sent home from the ER every single day. Every single day in America. I see 2 a week from the hospital, go home. I see medicine for vertigo, no CAT scan even done, nausea medicine and discharge from ERs all the time, because it masquerades. It can be so many other things if you don't listen to the story right and the onset right. It's also an area where because this vertebral artery, these two smaller arteries, they run up the cervical spinal cord. They're tethered, unlike the carotids. The carotids are just hanging out there in the breeze. There's deficits with that too, because they could be concussed very easily. These things, because they go to the brainstem, are protected in bone. And so they're very protected, but they're also, because they're tied down in bone, it's very easy when you get a neck injury to dissect them and tear them, because they're housed in a bony canal. And so it's a sort of an evolutionary trade-off. These arteries are damaged a lot in this kind of injury: whiplash injury, extension injury, decelerative injury, gunshots, bomb blasts, slips and falls. I've treated chiropractor manipulations. I've treated a couple roller coaster riders. I've treated a house painter that was up all day painting a house backwards, extended like this, that tore one of these arteries up. A couple beauty parlors where people have been back in the chair for 2 or 3 hours getting extensions or braids or other things, and then torn those arteries, and then go home and throw up for a day or two before they're recognized to have a vertebral or basilar occlusion or dissection. Sometimes people just go to sleep. I've had ICU patients that just are comatose for 3 days, and they work up 1,000 metabolic things, and then like the 3rd day they get a scan and realize the basilar artery is occluded right here, and they've been lights out and in a coma for 3 days, and it's not metabolic, it's not their kidney function, it's not their psych meds or whatever. And I'll never forget one guy, the young guy, was treated with Narcan like for a day in the emergency room, in a holding area of an emergency room, with Narcan, because they found a bottle of like Vicodin in his bag or something, gym bag. The guy had a bad disc or back problem, but he wasn't a Vicodin addict. He just happened to be the right demographic, and they gave him Narcan for a day and a half in the emergency room, and he had a basilar occlusion. He was a boxer, and he got hit, and he dissected a vert and got a basilar occlusion, and was laying there with a brainstem occlusion for a day and a half while they treated him with Narcan, because nobody thought about this area. So I tell residents all the time, you can't not think about this area. You have to. If you have dizzy, nauseous, vomiting, headache, nonspecific confusion that's not explained by a metabolic problem, you have to image the patient. This is malpractice to not image this patient. That area goes to the cerebellum, the balance part of the brain. So this is why we see a lot of dizzy, puking, headache people, drunk, staggering gait, with an occlusion of one of these branch arteries that peel off the basilar artery and go to the brain stem, and the balance enters the brain. The other area it goes to is the visual cortex back here. So we get people that can't see half their visual field, or they have a missing part of their visual quadrant, or they have visual hallucinations where they believe they can see things that are clearly not there, and there's a visual hallucinatory phenomenon with these people where they say they can see stuff clear as day that's not there, because their eyes work, but their connection between these vessels and the brain in that area in their cognition doesn't. It's disconnected. It's a disconnection syndrome, and they believe you go like this, and you go, how many fingers? And they go, 1. And they're looking straight at you while they say it, and they believe it. They don't understand why you're confused that they're saying 1. And that's part and parcel of that area. So how do we find people in the ER and screen for who's an interventional patient? And it's been this. So early on, about 15 years ago, we started using a lot more of this when this technology became available, called CT perfusion. Yes, we do vessel imaging like CT angiography to clearly look at the plumbing, but we also do imaging like this. Happens in like 2 minutes. They're doing it right now on a stroke patient in my pocket at the hospital that'll get bounced to my cell phone in a minute. And they look for areas of brain that are mismatched between the blood flow going to it and the amount of uptake of oxygen in the tissue. And when that's off, you get an image like this, where there's a quadrant, and you see where I'm going with this, that matches that plumbing and that cookie cutter diagram where there's quadrants that go with certain artery territories. I'll get a picture like that says, oh, okay, that's a middle cerebral territory on the left side of this person, right side being their left side in the picture. So that's definitely somebody I would expect to have language trouble and right-sided deficits. And the other thing this imaging does is it gives us 3 subcomponents of imaging that looks at the viability of that tissue. Not only can it tell us a quadrant of tissue and what region is not getting blood, but it can tell us whether it's alive or already dead. So it can tell us whether this is viable tissue that we can salvage quickly, or whether it's tissue that we could work all day to open that vessel and it's not coming back. We're not going to change functionality for the patient. So when these images match, and I'll make this concise, when the blood flow image doesn't match the volume image, when there's a mismatch like this where you've got something lighting up but it's not carried through the whole segment of films, this is live tissue that's going to die but is not yet dead. And this is where the rush goes on to go after that tissue, and it looks like this. And then we of course match that up with the plumbing images that we get from the CT angiography, and we correlate them. When we go to do a stroke case, this is where the metal really meets the road, and this is where a lot of the inertia and multidisciplinary behavior starts to take place. Because again, you've got to have anesthesia to put a lot of these people to sleep. You've got to have nurses, you've got to have x-ray technicians to run the machinery. You've got to give that medical therapy, TPA, in the emergency room before you go to the cath lab and attempt intervention with devices. Here are examples of those devices that we actually thread up into the head to do these procedures. These are ones called the Trevo and the solitaire retrieval device. They're little tiny little wires on the end of which is like a Chinese finger trap that we deploy through the clot, and then we cinch it tight and we hopefully get the clot out just like that picture and pull it all the way out of those vessels in the head if we've had viable brain to go after unplugging that artery. And a lot of these folks will wake up on the table and have better function within minutes on the table. Again, speed is all that matters. So that time in from the field, the treatment in the rig on the way in plays into how well they do, the speed in imaging, the speed in the reading of the imaging, the speed in all this multidisciplinary notification of me, the technicians in the lab, the nurses, the anesthesia folks. All this comes together in a matter of minutes. So we go from phone call to working in someone's head in like 10 minutes, 15 minutes tops. And that, you can imagine in a hospital right now what that's like, how painful that is for everybody. And my job in all this, I think, is the easiest in the chain. I'm just driving, and I can't do anything until the person's on the table, and I, got an artery in the leg to poke and go up and do what I do. I'm kind of this guy, but you can imagine all the peripheral things around me that I'm trying to navigate while this is going on, and we have to keep our eyes on blood pressures and physiology and the imaging selection and talk to families and get consent and make sure the ER is doing what it's doing and all this kind of stuff. And the speed of all this really minutes, 5 minutes, 10 minutes, like I said, can be dead patient or not dead patient. And so it really, really matters. So this navigation, I think for me and the vessels going up and doing the work is actually the simplest and easiest part of the process. I try to make that very fast, and I actually try to undo the lost time. I know the deficit going into the case of how many minutes we've lost doing what, and I'll actually make that up with how fast I can go sometimes to try to make up the difference. And this is one area where we can shine sometimes and take 10 minutes back or 15 minutes back if we're fast. A good multidisciplinary stroke case looks a lot like this. So if you're a fan of racing like I am and you watch Formula One, you know when I was a kid in the 70s, a pit stop was 12, 15 seconds. That was considered good. You know what they are now? Take another look. There's supposed to be a clock. Oh, there's a clock running. They're like under 2 seconds. So a pit stop today in Formula One's under 2 seconds. You change 4 tires, gas the car, sometimes adjust the front and rear wings, water the driver, and sometimes even adjust like brake bias and other things in under 2 seconds. And to really understand and appreciate this, you have to actually slow this down. This is slowed down, if you can believe it. So I slowed this down to like half speed. Watch what they're doing. One guy's coming off with the right front wheel as another guy's already making the motion to put one on. And the other guy with the air wrench is going into the wheel hub already tightening the nut, right? So if one of these guys isn't anticipating the proximity of the other guy, and I should say gals because there's both in Formula One now, but anybody's off here and it goes horribly badly. And that guy has to know that the wheel came off over there in my peripheral vision, and I see a guy over here throwing one on so that I can make that one motion to put that wheel on the hub. And so this is what a good stroke interventional case can be like if you have the right people and the right cadence. But when you don't get that right, it looks like this. This is a real Formula One race where somebody didn't get the wheel lug tight. Guy peeled out of the pits, wheel flew off, axle caught the asphalt, flipped the car, guy almost died. Stopped the race. That's what happens when a step gets skipped. So we're neurotic about checkoffs and steps in the process because they have to work. They have to be checked off or you get this in a case. That's why we're so neurotic about it. You can imagine we're not everybody's favorite people in the hospital service-wise because everything is so neurotic and methodical and speedy, but it has to be that way. This is the actual lab where we work, and this is an example of kind of what we're looking at when we do procedures. We can either go through the wrist or up through the artery in the leg. And again, these are the stroke devices that you've seen, and then we'll talk briefly about the other kind of stroke, which is rupture of aneurysms in the next 20 minutes, where we fill in a ruptured vessel and plug it up when it's leaking blood. So again, think of the plumbing analogy. It's leaky pipe versus stopped up pipe, that you're snaking a drain versus patching a leaky pipe, if you will. Again, in the process, this is what we're looking at. We're standing here trying to look at every monitor, every person that's not in the room in this picture begins to populate the room. So my view out the helmet I'm wearing looks a lot like this in real life in this room, and very similar to what they're looking at. This is a guy coming around a corner at about 115 miles an hour, and watch when he comes around the corner, the decisions he's got to make. All of a sudden there's 5 cars, he's all over the track, and if he doesn't get that right, he hits 5 cars. And while he's trying to look at this many gauges in front of him and read gears he's in and that sort of stuff. So this is very similar kind of business. That's just not a lot of room for error. After successful stroke cases, and we'll touch briefly on this is a biggie. We know now more than ever before that this rehab, that when I was a resident, I thought, okay, great, you're going to rehab. What is that going to really do? And then I went down to a very aggressive rehab center in the South, run by a guy that really knew what he was doing. And I saw people that I never thought were going to get out of a nursing home and eat again on their own, come back in my office in 4 months talking to me that I didn't recognize. And I finally got this guy, and I'm like, Clay, how are you doing this? And he's like, you got to start early, bro. You got to just get on him. The first day, start beating him around, moving those arms. And actually, since that time, there's been all this literature come out about first 24 hours, first 36 hours is highly predictive. There's scales about proximal muscle strength in the arms and legs, where if you can get that in the first 24 to 48 hours in tone, they can set their watch by what they're going to get back as far as functionality in patients. So this is not witchcraft anymore. This is all business. So people that scrimp on rehab and they send grandma to like Drooling Pines somewhere and don't really care about the post-rehab stroke care, doesn't work. It's not going to work out. Aggressive rehab, if you really want to get back to functionality, matters. Really, really matters. This is all business, all science now. Stroke prevention. This is the other thing in America we do a horrible job about that other countries like Scandinavia and the Netherlands and Europe, they do a way better job. Part of it is our lifestyles. We're like awful. I don't know, there's no better word for it medically, but awful. We eat crap. Our lifestyles are sedentary compared to Europe and other countries. Our stress level is through the roof compared to like Greece, where everybody retires at 39 and has lunch at noon and quits work at 11:30. And this is just a lifestyle in America that's different than other countries in Europe. The other thing we don't do a good job of is we've de-emphasized and taken the foot off the gas of primary care physicians. I have a good friend that I grew up with, went to medical school with. She's an extremely astute primary care physician, is double boarded in endocrinology, so she's about the best kind of diabetic and thyroid doctor you could get, and as a specialist in addition to being a very, very well-trained internist, and she's trying to see 60 patients in the office getting back $5 a note, and she can't afford to keep the lights on in her private practice and keep staff there and their insurance, because we've de-incentivized the earning potential for primary care doctors and insurance reimbursement, where they don't want to do it anymore. They can't do it anymore to make money. And so if you think they're going to see 20 people all day long and adjust their blood pressure and antihypertensives, they're not. And so patients don't go. And the other thing COVID has been bad about is it's de-emphasized people to go see their doctors. So they're going, well, I can wait 6 more months on my hemoglobin A1C, and maybe I won't go check my hypertension this month. I'll go next year. Like my parents do, put off doctor's appointments for next year or when their copay's better or whatever. And it's important because this is where strokes start. Strokes start with failure of hypertensive management. We know this. Hypertension, diabetes, cholesterol problems, undiagnosed AFib. It's relatively simple to fix and define. We blow them off, you're going to go on to have a stroke that might end your life. Best case scenario, might disable you. Why would you do that? If it was fixable, we got to get on this in America. We have this belief, like my dad does, that there's some magical dose of a statin that's going to counteract how many jelly donuts he eats a day and bacon, and it's just not. It's, Dad, I hate to tell you, it's a farce. You'll pay the piper at some point. You have to do the math and the hard work of exercising and dietary modification and do some of the things that they know about in Europe and they know work. And the primary care de-emphasis is killing us in the country. Aneurysms, touch briefly just for a second, small subsegment of stroke. It's a rupture of a blood vessel, right? So blood leaks out, all sorts of shapes, sizes, varieties. This used to be a huge part of my work at the universities in Chicago. We don't per capita see as much of it here in Rochester because people get kind of better care. But it's familial. We can see familial trends. We can also see 30-year-olds walking down the street and rupture one they don't know they have. About 6 people out of 100 have one they don't know they have. And they usually have 0 symptoms. There's this fallacy that you're going to know if you have an aneurysm. You don't. 99% of people walking down the street one day or jogging around the duck pond and they die. They just drop dead. 50% mortality. Very little time to get much of anything done. They die of raised intracranial pressure here, not the actual aneurysm rupture. The problem is the head's a closed space, hydraulic force, second, the volume goes up, pressure goes up exponentially, brain is squeezed, you're dead. And there's really not much room to do anything with that once these things let go. Common locations in the circle of Willis that I showed you earlier, aneurysms occur at joints of pipes, and the pipes leak in your house at joints, right? So that's where aneurysms form, where one force meets another piece of pipe and blows out the weak spot in the pipe. So, basal or tip, anterior communicating artery, middle cerebral bifurcating areas, common locations. I've seen them all over the years, all sorts of shapes and morphologies. Here's the first aneurysm ever done at Crittenden Hospital interventionally. This is a lady, about a 59-year-old lady. She was at her son's graduation last year at Oakland University. She's standing there on a Sunday at his graduation, gets kind of a crappy headache, starts feeling woozy for a second. Felt like somebody snapped her in the head with a rubber band. She said, weird headache, kind of felt like she was going to throw up, kind of sat down, got through the rest of the ceremony, went home, actually had cake with them and stuff, got up the next morning, couldn't stand up. Headache, vomiting, horrible, like she'd been drinking for a whole weekend, she said. Comes into the emergency room, gets Narcan again, treated for opiate overdose because she'd been on some back pills, a lot of back pills for back pain, but she'd taken more of them because she thought it was going to help her headache. They assume she's pain seeking and they're about to discharge her. And we asked them for this, well, actually she gets admitted. So she's admitted to the hospital. And then the next day we get a consult because there's unremitting headache with a family history of aneurysm. We scan her and she has this. So this lady, what she actually has is a partially rupturing aneurysm. You see the little nipple on the side of the thing in multiple locations. This is called a sentinel rupture, where people don't blow out the aneurysm. They get a little bump in the dura from the bulge in the aneurysm, a little spurt, if you will, and it doesn't blow out like a ruptured tire on your car completely. It just leaks. They get a little spurt of blood, it leaks, kind of self-seals, and then they're fine. And that's what she had, and she had been getting ready to rupture this aneurysm. So that was, prior to this date, back in the 80s, it was a good era for Crittenden. There was a lot of open neurosurgical work going on there. My mom was actually the beneficiary of a old-time neurosurgeon that was there for years, that was very well classically trained, that could clip vascular abnormalities like that. But we've had a lag in that kind of work going on. This was our return to first aneurysm work at Crittenden last year. So let's go to some real case examples. I'll try to close with some of these. Our goal in all this, like I said, is to help partner with EMS, help the ER turn a really bad day into a survivable day, if you will. And that's what we try to do, hopefully, is make these non-lethal scenarios where people can go back home despite the gravity of these. And these injuries kill as many as 50% of customers. So I feel like the only part of what I like anymore in medicine is that the people I treat are dying. There's really no room to go but up to try to treat these people acutely. And I love that part of the work. But everything else in medicine I could do without at 50 now. But I still love that part of it. And if you're having a good day and you're on and everything happens correctly, you can really make a difference. So it's a real case. Clock's running. Lady, 85 years old, hour or two, last known well, left side hemiplegia, can't move her whole left side, arm and leg, is looking off to the right side, not looking at you on the left. She's got a stroke score of 16. That probably means nothing to anybody, but it's high. I'll just tell you it's high. It implies high level of disability and large vessel occlusion. Here's her scan, the perfusion scan I talked about, walking in the door of the emergency room. So I'm gonna have you read that one. So this is her right side of her head. So what's going on there? She's definitely got a lack of flow to the right quadrant, right? Kind of that right middle cerebral quadrant. You would agree. We shoot a film of her, take her to the cath, and it's all viable, by the way. There's no dead tissue, which would be in pink there. There's no mismatch. In other words, this is all live tissue. We take her off to the cath lab where she normally would have this. She's got only one branch, you see there? Normally she'd have a bifurcation that should look like that. And so what we did is, here's the retriever. I don't know if you can see the little dots. Those are the feet of the retriever that are up in that vessel, opening up this bottom branch that had been out. You see there's only one branch there. It's subtle, I agree, it's subtle, but this was a life-ending stroke she was about to have at 85, and one pass and open, 15-minute case. And she got in there 2 hours after onset, actually ended up getting some rehab, but I believe did pretty well. That's the feet of the device. And then when we work, you can barely see them. You just see the outline of where the front and the end of the device is to park it, basically, is what I'm looking at. Here's how it works. So here's a cartoon. So I'm up the right carotid artery. This is that case in cartoon form. Device goes out through a catheter. The catheter is distal to the plug of clot. Device comes out of the tip of the catheter. Catheter gets pulled off. The device gets thrown out. It evolves like a Chinese finger trap. It entraps the clot, and you yank it back into a suction catheter that's in the neck right there. And that's about real time. That's how fast we do these in real time. And again, this is what we're navigating to go do that, believe it or not. So that's, again, a cartoon of how that would work in real life. Here's another example. Auburn Hills Fire Department brings in an 89-year-old lady, high stroke score, can't talk or understand any spoken speech at all. Right side flaccid, can't move her whole right arm, right leg. They give her some oxygen, and her oxygenation was really poor in the field. They didn't really give any O2. Blood pressure was very low. She had been down for quite a while. Blood pressure very low. She's in AFib, so you know the mechanism here. Just incomprehensible speech. This is what we got. Total time on scene. They spent a half hour just packing her up at her house. She comes in. Here's her film. So obviously a big left-sided deficit on this lady, but almost the whole hemisphere is out on the left, which was odd, not just a particular vascular quadrant, but almost the whole side of the head on the left. We shoot a film based on that, and of course what's out, the carotid artery is out before it even makes it into the head. So I go up the left carotid artery with a very large sucker and stroke device, and I get a surprise when I open up the clot that's about right here in the neck, right outside of her jawline, and I see this. She's got a massive aneurysm the size of a Titleist sitting in her carotid. And what this thing had done is act like a sink. Blood had just swirled in this thing until it clotted off from low blood pressure and formed a clot, and then stopped up the rest of the carotid below where this golf ball sized aneurysm was. And the way we actually did that, of course we don't do anything with this acutely, but what we had to do is find the lumen of the vessel. You see it's a little tricky here, and go through it up into the head to do a thrombectomy, and then come down through the aneurysm and leave the vessel open, which we did. And she actually would have lost the whole hemisphere. Her stroke was confined to just a small little quadrant here that you see on MRI. She did have some speech deficits, but this would have been a life-ending, phenomenon there. Here's another example. This is a really good example of everything perfect. This is a 59 or 60-year-old lady who had just kind of retired early. She was eating dinner with her husband. He's washing the dishes. She stuck him with the dishes. She goes out in her garden outside behind the kitchen window. He's literally doing dishes in the kitchen window, looking at her out the window. She's doing some late evening flower planting, and he sees her go face forward into the flower bed. He runs out. She's having trouble talking to him. Literally brings her to the hospital himself in the car. She rolls in. This is her scan. Of course, whole left middle cerebral quadrant is out. We immediately don't see a big core infarct, just a tiny bit of core infarct here already brewing at 15 minutes. She hits the door at about literally 10 to 15 minutes from when this happened in her backyard. She was literally like right across the street from the hospital. Whole middle cerebrals are, this is a 100% lethal phenomenon usually, or best case scenario out of this, you're going to get a 60-year-old lady in a nursing home with a feeding tube that's never coming home if you left this as it is, if she survived. Time of the entire case was like 12 minutes. So up, out, this is 12 minutes later. So the whole case was done from flower bed to vessel open was a half hour or less. And she walked out of the hospital in a day. This is her post-scan. We typically will see a little bit of contrast that'll sit in the area where the core infarct is, where there's been breakdown of this in an inflammatory process. This is a good picture of inflammatory areas take up contrast. So the next morning, she's talking to me she's calling me on her cell phone at home, and she's fine in the ICU. We scan her that morning, and she's got this, and everybody freaks out that she's got a hemorrhage, and she's talking and fine. It's just contrast sitting in this angry area of brain. 12 hours later, it's gone because it just washes out of the tissue. I always show this example of the hemorrhages that go away in 12 hours because people have a hard time understanding these aren't hemorrhage, they're just contrast lingering in hurt tissue that's inflamed. So she was a great story. She actually did a testimonial for the hospital. It was one of our first big, stroke testimonial people, and she was really happy to be part of the process, of course, across the street. It's another case, 79-year-old guy. He's sitting home one night watching TV. Tries to go get up and he falls flat on his face. He can't get up, and his whole right side is out here in the picture. You can imagine when he comes in. He's at like an hour or so from onset. By the time he gets picked up by EMS and into the hospital, it's like 2 hours for some reason by the time he gets imaged and they contact us. And he's got the whole right side that's largely at risk. A little bit of core stroke. It's already dead there. We take him in, he's got that picture, fits, right? You're expecting that from that picture. Right middle cerebral artery out, and I'm sorry to do too much anatomy for you, but I'm trying to make the case that you can not be medical and understand the plumbing of this. This is not hard. It's out, retriever goes out. Here you see those little tines of the retriever there. Pull back, and you get this, and we notice he's got a piece of plaque. Do you see that white tooth looking thing there? It's a big piece of plaque that just dissected off the surface of the lining of the artery. This is too many bagels and, cholesterol-laden pancakes and scrambled eggs and, donuts, and a piece of plaque peeled off, and it's acting like a valve. So even though I'm pulling a retriever through there, the second I come out, it all just shuts back down because he's got this hard calcific piece of plaque that's waving around in the breeze there. So what you see there is a balloon. Do you see the little dot there and another dot there? We actually had to go out with a small little 2 millimeter balloon and tack that plaque back open. Sometimes we actually have to stent it back open. In this case, this guy stayed open, and you can see when I ended the case, you can still see this little hurt piece of plaque sitting in the artery, but it's open now. And he's breathing again on that side. We try not to put too much metal in folks because, again, you don't know what kind of core injury they've had. And if you can get out of these cases by pulling down into the carotid and sitting for a half hour and just watching to make sure that vessel stays open, sometimes I'll do that. Because if you put in a stent, now you're committed to high-powered irreversible blood thinners. And oftentimes people will make the mistake of doing that willy-nilly and then throwing people on heparin and Plavix, and the next morning they're dead in the ICU because they've hemorrhaged in the dead core area brain. And I knew he had some core. So this guy survived and did a week of rehab and went home at 80 with this. And he lost 2 hours where there was nothing going to the whole right hemisphere. This is one of my favorites, and I invited her. She didn't take me up on the offer, and I think she's a very timid little lady, and she's freaked out. But so this is, I don't know, when do we do this in Rochester? I can't remember. When do they do this? Like November. So I'm sitting on a street corner with the lady from Stryker in November for the lighting ceremony, and we're having coffee, and I'm helping her corral her kids that are running around and keep track of them. And we're standing on this corner. We're on this side of the street. On that side of the street, unbeknownst to me or her at the time, there's a 37-year-old lady with 2 kids in a kid carrier that she's shuttling around the street corner that night. And she is on the street that same night, I found out later, for the lighting ceremony. We would meet later about Christmas time in the cath lab. And so she is 37 years old. She did not know she was COVID positive. She had had the sniffles and a relatively asymptomatic COVID course around Christmas time. All of a sudden one night, in front of her kids and her husband, she starts stammering and can't talk. And he doesn't understand what's going on. And he's confused, and he thinks enough to just, I don't know, let's go to the ER. ER treats her as like a urine drug screen and some other stuff looking for metabolic causes. And the ER doctor adeptly very quickly realizes she's freaked out. This is not normal. This is not the demographic. Something's wrong here. Calls me, and I go, yeah, let's scan her. You can never be too careful. COVID's out there, and sure as hell, she's got this. So she's got maybe half of her left hemisphere lit up. What area? We talked about it. Yeah, frontal lobe, right? Some of her parietal and frontal is out. This is why she can't verbally express speech, because it's frontal, but a lot of her parietal is still getting blood flow here, half of it at least. So when I talk to her, I go, hey, can you hold up 3 fingers? And she'll go like crying, like hold up 3 fingers. But she can't verbally talk, and she is flaccid in her right arm, but she can move her right leg. And that makes sense because she's only got half of her left middle cerebral circulation out. So we obviously rush to take her to the cath lab. She collapses en route and loses her airway, and we intubate her rolling down the hallway to the cath lab. And while they're still intubating her and cutting her clothes off, I'm already in her chest with the catheter and making my way to the left side, and I shoot that picture. And you'll see in this artery, this is the middle cerebral trunk coming out, and then what should be a split where there's 2 bifurcating branches. What do you see there? Fluffy white stuff there in the top one particularly. Can you see that area? I don't know if that shows up. Procoagulatory state. This is a young lady on birth control pills, didn't smoke, which is another procoagulatory scenario, but birth control pills, just had fresh COVID, set up the perfect hypercoagulable state. And she had not been getting a lot of fluids at home and kind of under the weather, sniffly all day, not eating much, felt nauseated. Had a COVID scenario, built up a huge clot until she closed off half of one of the 2 branches of her left middle cerebral circulation, right there. And we went up, and that's what I took out of that superior division branch on the end of a solitary retriever. And this is 10 minutes later. So this lady would have probably never raised her kids, never gone home. She'd have been in a nursing home. And I think we only kept her like 48 hours. We just want to screen for cardiac issues and we sent her to a hematologist to look for hypercoagulable states, but you can imagine their take home on that was probably COVID. And since then, God, I've seen a lot of this since then that have been COVID related, also vaccine related. Here's a 55-year-old guy comes in positive for cocaine and screening, behavior's weird in the emergency room. He's also got COVID positive test, but he has no symptoms at all. He's also testing positive for amphetamines. Gets that image on the way in. Again, left side, about half the circulation out. We shoot the image in the cath lab because he's very viable. And you see that stump right there? It's hard because there's lots of vessels laying over it. But he's got a stump right there of the middle cerebral artery. And here's the retriever stuck through it. Can you see the little tines here? This little patchwork is stuck from here to here. That's the retriever. Here you can see the end of the retriever in what should have been a vessel open there. And the next day, here's his MRI, not a mark on his MRI. So he managed to walk this off without even leaving a dot of stroke on his MRI because it was just such a fast case with the vessel back open afterwards. Here's an example of this danger area, this posterior circulation, brainstem, basilar artery. Sadly, this person was admitted to the ICU for metabolic derangement and confusion and encephalopathy. They stayed 2 days, were worked up for renal problems, sepsis, a host of other metabolic derangements. They sort of corrected all those, and 48 hours later, the patient still wasn't waking up. They thought to include stroke in the differential 48 hours later whilst in an ICU, and they bring them down in the middle of a day for this scan. Well, what's the distribution tell you about this scan? Odd, right? Not an anterior circulation hemispheric problem, it's brainstem, right? What's lit up? The whole cerebellum, literally. The entire pons and midbrain lit up as well, yellow there, see it? And we do the CTA, and this is what this guy's got. You see the white area? You got to squint, but there's a big teed up clot sitting right at the junction of the top of his basilar artery and the two posterior cerebral arteries. It's the blank spot you see between the white. In a tiny little area, but kill you dead. And sitting in a hospital for 2 days. 20 to 25% of all acute strokes are actually posterior circulation strokes. If that doesn't scare you, I don't know what does, because it's not bad hospital. I'm not throwing anybody under the bus. This goes on every hospital, everyone I've ever worked in my whole life. They miss these because it's this, 75-year-old septic shock patient that's got renal insufficiency in one kidney, and they just get suckered into metabolic, and then nobody ever thinks plumbing, and then till you do, and then it's too late. And this guy, sadly, was 100% infarcted by the time we did the scan. There was nothing we could do for him. But you got to keep this. If you got people without an explainable metabolic cause and there are lights out, nobody home, you have to think plumbing. Aneurysms, like I talked about and touched on, what kills people isn't the leaking blood or the aneurysm that's ruptured. You can fix those. It's the rise in intracranial pressure that literally squashes their brain. And what we do to mediate that acutely is we cut a little hole, we put a little drain in the ventricular system as a shunt to shunt off that pressure. It sounds grisly and ghastly, but we literally do this on the table before we're doing the angiography. It takes 10 minutes, and literally residents do it. First-year residents in neurosurgery do this. It's not hard. It's actually fairly straightforward, and it's life-saving to equalize that pressure before you can even work on patients and begin to fix the aneurysms. Here's an example of this entity. I don't know if you've ever heard this coiling. We quote-unquote coil an aneurysm. This is what we're doing. Well, in the old days, they would take a clip and they'd open your head and they'd put a clamp across the neck of the aneurysm like you were clipping a bag of potato chips to keep them fresh. Today, 90% of aneurysms are done this way, which is how I trained. You go up the same way with a catheter. You actually gain entrance to the aneurysm with a tiny little wire and catheter, and you fill it up with material. It's like filling up a bathtub with concrete, so no more water would fit in the bathtub. And that's how we seal them off once you've addressed the intracranial pressure issue that's going to kill you. And these are some of the examples of the differential coils we use and mesh work that we put in the aneurysms. They're like the consistency of human hair. They're made out of nickel, titanium, and non-ferromagnetic alloys. And we literally weave them in real life, in real time inside of the aneurysm to fill up the space until we're happy the aneurysm's not getting flow anymore and the intracranial pressure is normal. And we've mimicked as much as we can normal physiology in the head. This is the first one, like I showed you, ever done at Crittenden Hospital. There have been multiple since to return us to an era of doing minimally invasive neurosurgery work there. but somebody was photographing this the day we did this on this lady from Oakland University that had this very large, partially ruptured aneurysm. And so this is an example of what this looks like. So as we go up, we're putting a catheter in the aneurysm. We're beginning to frame it with a framing stiffer coil, and then putting smaller, tiny finishing coils inside of it. And that's what it looks like when we're done. So when you're done, you just have this left metal, no aneurysm, and metal taking the place of the aneurysm. This is one of the PAs excited with another aneurysm that was done after that, where a lady had an anterior communicating artery aneurysm. You could see it literally hanging between the branches of the anterior cerebral arteries. Again, we use three-dimensional films. We can actually make 3D models of these things while we're doing them to make sure we are where we think we are in 3 dimensions while we fill them in with material and then look at them in 2 dimensions. In real life, we can make 3-dimensional computer models of them by doing injections, and we can make a 2-dimensional object into a 3-dimensional object in a computer to double check our materials and make sure all the vessels are open. That's a good example of the framing coil that goes in that takes the shape of the aneurysm before we get inside it, like a Russian doll technique, and then begin to fill it in with other material inside. Here's a nice picture of a catheter dunked inside. That's a white dot. That's the moment the catheter enters the aneurysm. It's sitting in the belly of the aneurysm, and then we begin to fill it in here sequentially. Here's a very nice high mag photo of what that looks like. This is what it looks like when I'm working. So when I'm looking out the helmet, this is what I see in the picture. Catheter going into the aneurysm. Dot right there in the middle of the aneurysm is the catheter tip. This tells me the proximal end of the catheter. This is the distal tip, and that I'm deploying the framing structural coil in that aneurysm at the time of this picture. And then you have a catheter, a telescope catheter. It's lower down in the neck for support. And this is what framing the aneurysm looks like the instant you're doing that. So with that, I'll leave you with a couple of other things here real quick and be done, and I'll answer your questions. This is a way to get a hold of me. If anything comes up, it's a question that I didn't touch on, you got a question, feel free to email me. I look at these daily at that email. I'll be happy to answer them, or I'll boot it to Lindsay or somebody in the industry. If it's an industry question, she'd be happy to answer as well. And normally she'd be here to help. And she has models of the device, and we're happy to do that at a later time, come back and talk to you about some of that stuff. Again, I usually close with slides like this. Think about that. Prior to 1995, when I showed you that picture in 1982 of me in the go-kart, and I've mentioned some racing analogies along the way because I'm kind of an amateur car racer. Nothing existed. So in the 80s, people just died. There was no medical therapy to even throw at somebody, clot-busting medicines. It wasn't until 2015 that there was any literature that suggested there was even a reason to do catheter-based intervention. 800,000 Americans a year dying or getting disabled. You can imagine the bodies and the count that has accrued over half a century here in America, where we've done other hard things in the country, and all these lights that kind of went out around the country from disability or just failed opportunities or entropy in infrastructure or financial ups and downs of medicine and the pharmaceutical industries. And there's one of those going on right now, actually, and we'll touch on it in the next slide, where we're changing what we do in stroke care because of the cost of it has caught up with us. Not medical reasons, financial only. Staggering to me still that we're still doing this, knowing that we lost this many people a year, and it took us this long till 2015 to get back in the game a little bit. So I race 3 different classes of cars, and this is one of those. And my first foray late last fall, I was at my first major track, a pro track in Ohio. I don't know if you guys know this course, Mid-Ohio is an IndyCar track. So I was allowed to get loose in a very fast car at an IndyCar track while I was under some training from some good people to learn to drive at a much different level of driving than I had previously. And that's one of the analogies that I tried to carry through the talk. Is it took me a little while. I went out, of course, having done club racing here, and it was just a whole different ball game, whole different world. And you're talking 130, 40 miles an hour as opposed to 90 or 100 is a big jump, big learning curve, and very different cars. And I go out, and I don't want any part of it. I come in, and I got this look on my face, this terrified look that my father captured on my face. This guy is our team manager. He's one of these wise old Southern guys. Unfortunately, he even looks like Ricky Bobby's dad in the Ricky Bobby movie. He sounds just like him with a bad Southern accent. And I came in just about ready to unbuckle and get the hell out of the car and be done for the day. And he's like, "Son, you need to just tell me what you need. You need to tell me what you need. Tell me, talk, use your words. Tell me what the car's doing. What are you feeling?" And I was just I couldn't even explain to him what was going on. And I tried in a non-racing terminology to explain what I was feeling at the end of turn 1, which is like a 130 mile an hour turn at the end of the long straight at Mid-Ohio that goes into this really abrupt right angle turn that if you don't get right, you're off the track. And the back end of the car was slipping, and I was trying to express to him my anxiety level at the back of the car slipping around the turn and getting loose on me. And he's like, I got it. He goes, like throws wrenches all around and click, click, click. He's like, go drive it. Just drive it like you stole it. And I'm like, are you serious? He's like, it's not gonna do that. I just needed to know what you need. I need to know what it's doing. I need, it's expertise of all the different disciplines is what makes racing work. Guys that drive these cars, most of them don't know a damn thing about the cars. They don't know anything about how to even articulate the setups of the cars. But there are people that do. There are people that know every bolt on that car. And if you can describe to them what you need to get something efficiently done and do, he told me, you go do your job, I'll do mine, if you tell me what you need. So I go out, and I actually ended up finishing that day with very competitive times, the minute 37 point, because I listened to this guy, and I could begin to articulate what I needed to get my job there on the track done. And it's a great example of a multidisciplinary team. I usually close with this quote because I had a good nurse practitioner that I worked with for years that she used to get mad that all the administrators at the hospital always had these catchy like philosophy statements at the end of their emails, where they would quote like Voltaire or Socrates at the end of their emails. So she put this quote at the end of all her emails that she would write to people. It said, "Cupcakes or muffins that dared to dream," Betty Crocker. And I think it's appropriate because if people hadn't have stepped outside the boundaries in 1995 and thought like, I don't know, it seems sort of stupid that in 1995 we should just let 800,000 Americans die of a simple plumbing problem when we're going into the heart, we're fixing heart vessels, we can do all this stuff. Why would we not go a foot higher and try to do something? And then it took, another 15 or 20 years till we could actually go up with actual devices and somebody would let us or validate what we were doing at least. And I've literally been escorted out of cath labs in the early 2000s by security at hospitals, by med staffs. So I will never forget those days for doing, unlicensed procedures or evidence-based procedures. And interesting, so 1996, no therapy for stroke. TPA is just introduced about that year. Nobody wants to use it. I can remember being a resident and people would make excuses not to have to give it. They didn't want the liability of hemorrhage. First mechanical stroke device is introduced in 2004, but the literature lags till 2015 to validate it. 2015, first indication for thrombectomy, goes a long time. And now all of a sudden, early this year and late last year, suddenly TPA is banned since 1995-96 because it's become cost prohibitive. Cost prohibitive to hospitals. We can't give it anymore. We want to use something else that has very little evidence behind it. There's been 1 or 2 studies that validate tenecteplase as the agent of choice to use instead of TPA because it's much more cost effective for everybody. However, and it works, it's got relative indication where it's not really a lot worse or less efficacious. However, it doesn't have literature since 1996 to back it up is the problem. And the legality of it's complex. And hospitals are struggling right now because they're forced into a spot where because of cost, they're giving up, Ascension is one of them, we're giving up using TPA now across the board, all Ascension hospitals, and we're being directed to use this instead. The problem is the American Academy of Neurology hasn't issued a policy statement yet that says that this is a guideline to use tenecteplase. So we're asking physicians to use derivative information from insurance companies based on cost to give medical therapy that isn't by their boarding indicated yet. And it'll catch up at some point. The American Academy of Neurology will follow suit and have some indication that tenecteplase replaces TPA. But you can see what position this puts physicians in and hospitals in that are, obviously hospitals can't afford to pay 22 grand a dose for TPA anymore, and it's come down to about 10, but tenecteplase is like 4 or 5. So the cost savings is immense. And this is the medical era we're living in today. So you wonder how long is it going to be before all of a sudden this becomes a sketchy cost-related phenomenon, right? Do you know what those devices cost? It's $8,000 to $10,000, sometimes 12 per device. Sometimes we use 2 of them in a case because we have to use a smaller one to get out more distally and then get to a proximal vessel, use a bigger one. So you're talking about a $25,000 case. At what point is that going to become prohibitive? It's just a scary slope that we're on. So again, just to reiterate, there's so many people in the process, from the field, EMS, cath lab, radiology people, ER people that do a lion's share of the work, sometimes with some of these time-sensitive illnesses. Anesthesia people can make or break a case, how fast they are getting somebody to sleep. I can't work on a moving target. I do sometimes, but it's hard. We're working in 2 millimeter or less big vessels. You can imagine poking around with a sharp object in a 0.5 millimeter vessel when somebody's moving in front of you is tough. And so my safety depends on looking over and them saying, what do you need? Looking at a nurse or a tech saying, what device do you need? Or sometimes I'll be standing there struggling and a tech behind me will say, I got a curved wire that probably gets you there easier. And I go, bring it. It's a good idea and it can save you. And so it's a team multidisciplinary phenomenon. When it works right, it works just like that Formula One video. And it's a beautiful thing when it works right. If any of you are interested in racing, by the way, 2 weeks from now, there's a U.S. national major up at Waterford Hills that's going to be a big event where they're going to have a live IndyCar from the Indy races on display. If anybody likes racing, stop up. It'll be a good race 2 weeks from now up at Waterford Hills. I'll take questions with that, and that's kind of what I wanted to leave you with the last 20 years of stroke and intervention. And I know that's a lot, but I'll be happy to try to answer questions or email you back if you got questions or concerns. But be stroke advocates. Again, you're talking about 1 out of 6 people. It's not like, leprosy. It's a very common disease. So the question is for you as a consumer, you in your home city to ask, is the infrastructure there? Is it going to be there for me? Are hospitals in the area taking this seriously? Are they doing what they advertise they should be doing? When you see a digital billboard that says stroke program on the front lawn of Crittenden, or is Beaumont doing that? Is Henry Ford doing that? These programs are all accountable for everyone's safety at some level. And being a medical consumer these days is not a dirty word, and asking questions is a good thing. When people get economically stressed, they cut corners. There's no question we're in a nursing crisis right now in the whole country. So asking questions and being aware of anything you can do to mitigate stroke on the front end, you're going to be way better off to treat stroke as a risk reduction strategy before you're in an acute scenario. I can't emphasize that enough. And how tragic it is that a lot of the primary care physicians have been de-emphasized and de-incentivized in the process where they can't afford or aren't able to do a lot of what they used to do to mitigate finding AFib, diabetic control, hypertensive control. Bread and butter preventative medicine is not happening anymore. It's been shut down the last 2 years, and it's tragic. And it's been troubling to see some of the missed opportunities for rip-roaring AFib and aneurysms before they ruptured if somebody would have gotten them screened properly and that sort of thing. So, try to keep it in your mind if you're having TIAs or if you're at risk because of family history or personal risk factors like smoking or cholesterol or hypertension or cardiac concerns about cardioembolic sources or any rhythm-related abnormalities or trouble like that, worth getting screened. You can go in for one appointment at your primary care doctor's office if they do a lot of this and get your hemoglobin A1C checked, your cholesterol panel, carotid ultrasound, cardiac echo written for to do over time, and a lot of things that could really take your risk down a lot if you do these things and they're all negative for stroke. The other one is wearing a long-term telemetry monitor. This is becoming more common. It used to be very hard where people had to wear these giant Walkman with wires and all this crap that you had to wear. Nobody would wear these for the whole month. Now it's like a stick-on Band-Aid the size of your finger that you can stick to yourself and wear for a month and take showers in. At the end you peel it off and put it in a return envelope to the company, and they can tell every minute of heartbeat for a month what you did and whether there were any runs of AFib or arrhythmias that would put you at risk for stroke and stuff. So it's a big deal. And the medicines these days for AFib, if you are part of America, 20-30% of America that has AFib, the medicines for it are very game-changing as far as their risk reduction for stroke and easy to take. They don't require a lot of the monitoring that Coumadin and some of these drugs used to have. And for people that can't take blood thinners for other reasons, there are all sorts of interventional cardiac alternatives now to being on these blood thinners, like little cages that they put in your atrium to keep clot in your heart rather than being able to get ejected from the heart that they implant to negate you having to be on long-term blood thinners for life. So there's lots of other things to do. Just don't get caught without having thought of it. If you have risk factors, it's not worth being in these circumstances, because by the time most people get to where they're getting treated by us, they don't have options left. It's go time, and they have a 50-50 chance of doing well, and their clock of disability is already ticking by the time they hit the door. And again, everybody's different. We work on people that have been down. I worked on a guy once that was down 24 hours, and he walked home from the hospital. Just was lucky, he had enough collateral reserve. good EMS care, good hydration and stuff. And then I've worked on people that have had 20 minutes of downtime that are nursing home for the rest of their life or dead. They just didn't have a lot of reserve. And so everybody's different. It's why we run to every case. It's why I live a block from the hospital and have done this kind of stuff for 20 years. It's because the time, you can really save yourself a lot of trouble by the time management of these. So thanks for coming out today. I appreciate it. And yeah.
My issue was probably, I kind of knew that I might have a stroke. What happened, I was able to start taking all kinds of medication. All of a sudden my weight shot up, and I was up to 300 pounds, so I stopped my medication. So for 15 years, I didn't take anything. My blood pressure was probably 270 over 230. My weight was at 300, which had never been that high before. And the way I had it, I felt nauseous for about 0.2 of a second. And then I felt it go all the way up to my brain, started basically seizures for 10 minutes. Then it stopped. When it stopped, I couldn't blink, I couldn't move. I had absolutely no feeling whatsoever. And it took about 8 to 10 hours before I could just do one movement. And I would wait. I figured I got 2 weeks to make it out the street. Somebody will find me then. So that was on a Wednesday night. Saturday, my sister found me. So, and it was a hemorrhagic stroke. I didn't know I was having a hemorrhagic stroke.
In your case, probably blood pressure related. That's off. You fell off the top edge of that curve,
Yes.
and you bled, and you're lucky you're alive because most of those folks die.
Right. And you know, I didn't know I had the aphasia. Of course, you can't tell, but my speech was not. It was impaired, but it wasn't gone. So it was more slurred than it was absent.
Gotcha.
I started reabsorbing the blood, and
It does. People that survive a hemorrhage without intracranial pressure issues, the blood sort of resorbs like a bruise and goes away over time. And it sounds like your scenario, you were relatively lucky. That's awfully high blood pressure. And sometimes once that starts bleeding, it's just like a pool that expands until people die of it.
fall over.
Yeah.
Straight up.
I was going to show you guys. This is the patient sitting in the emergency room right now. So I'm like, while I'm standing here, I'm looking at him for ischemia. So there's nothing. It's a negative film. So this is metabolic or something going on. That's not ischemic or stroke related, but it's an example of the technology that lets us stand here while we're giving a talk to you, and I'm looking at this guy's scan in real time, knowing that it does not going to need to involve me. He doesn't need clot busting medicine because it's not ischemic. You can't trick this film, in other words, and so everybody gets screened the same way in the process. So it's nice, and now the technology is ubiquitous. It's on phones, it's on smart devices, and we're able to look at his blood vessels in real time as well. So I'm getting a map of all the blood vessels in his head while I'm standing here, and can at a glance tell he's got nothing major out, and so it's nice. You can imagine before this technology existed what a pain this was. You'd have to go to the hospital, wait an inordinate amount of time for the images to get actually read or downloaded by a radiologist. Now a computer comes out of the machine, boots them directly to me, and I'm looking at them as they're coming off the scanner. So it's a nice way to do things today. It saves that evolution alone has saved a lot of people's life from the days where it would take 3 hours to go out to a radiologist somewhere or get a report generated. They got faxed back to an emergency room. Big, stupid, but it's a big deal. Big deal.
I have an issue with pain, but it's cross-linking. So what happens with this hand is the one that feels the pain. And actually, the worst thing for me, stirring oatmeal causes this hand to feel like I'm having a stake through. So I'm not sure exactly why it.
No, that's a pretty well-documented phenomenon. There's all sorts of entities like thalamic pain syndrome and stuff where people injure some areas of the brain in a hemorrhage, and the thalamus is one of those areas that's really prone to hypertensive bleeding. You may have had a left thalamic hemorrhage or something. That's a relay center for pain, and it's not a direct sensory cortical area, but it's a place that's wired to the sensory cortex. And so when that area gets injured, it's like permanently setting on a thermostat where it's like setting on a relay for pain that's always on or is triggered by certain things. And so we have people, for example, with limbs that are amputated where they've had an injury to that area and they have extreme pain, like the limb is still there, that's different than phantom limb pain. We've had people with car accidents where they've had concussive type injuries and they get a small hemorrhage in that area and they have like chronic pain for the rest of their life. from this on switch being turned on in this sensory relay area.
Do they do things with virtual reality where your brain actually sees what it thinks is going on, but it's not real? Will that actually cause the brain to change its behavior?
Some of that gets better over time with kind of habituation to normal stimuli and stuff, but people have problems that are sometimes hardwired, like these people that injure the occipital cortex. It's a horrible thing to watch, and I've seen numerous examples throughout my career where somebody gets a very small infarct, but it's in the wrong place. It's right slap in the middle of, a territory that controls the brain's awareness of visual input. So the people can talk, they can move, they can walk, but they're tricked by an unwiring phenomenon where their eyeballs work and their optic nerves work, but they're going to an area of occipital cortex that's disconnected. So they can look out at a scene and tell you, I see 2 dogs in a tree and 2 kids playing on a merry-go-round, and they're looking at a parking lot with 2 cars in it. And they can't tell the difference. There's also a confabulatory phenomenon that's well described in the literature where their brain makes up a scenario to cope with the fact that they have a visual disconnection with what their eyeballs are actually looking at, and the brain can't take up all that, and it makes up a scenario to fit the scenario. And so you ask them to hold up, you hold up 3 fingers, you say, how many fingers am I holding up? You're not holding up any. They'll look at you like dead to rights, look at your face and tell you they're not seeing anything. Or they'll set off call buttons and say, get this person out of my room, I don't want them here, and there's nobody in the room. They see stuff visually. To them, there's a perception there's something there that's not. It's also one of the problems with a lot of these Parkinsonian plus syndromes. They're very linked to, there's a couple of those that are linked to visual hallucination. And so the reason that people don't do well is sometimes they get very psychiatric. Their Parkinson's doesn't kill them. They get psychiatric because they believe all sorts of hallucinatory ideations are real as day to them. And they think people are chasing them, or they're getting somebody stalking them and trying to kill them, that there's nobody there, and they don't die of Parkinsonism. They die of psychiatric illness and suicide because they can't cope with the visual hallucinations that come with some of these Parkinson's plus syndromes. Yeah. We didn't used to know that. 20 years ago, 30 years ago when I was a resident, it was Parkinson's, that was it. Now there's like 14 syndromes that are, progressive supranuclear palsy and, olivopontocerebellar atrophy and all these subcategories of movement disorder that are very subtle, but that carry with them all sorts of psychiatric diagnoses and other autonomic instability like Shy-Drager disease that Johnny Cash died of, and people like that have the side effect of the Parkinsonian syndrome is they have cardiac arrhythmias and autonomic dysfunction and lose their ability to swallow and other stuff that have nothing to do with the Parkinson's. I haven't done that stuff in 25 years, but I'm just kind of a plumber now, but it's a field of neurology has expanded violently over the last 20, 30 years from just being a very general science to being highly, highly, highly specialized now, where people that do one segment of it, like me, for example, I literally started out training in 2000, when I got out of med school as a psychiatrist and general neurologist, and now all I do is intensive care and plumbing in the head and aneurysms. So I have nothing to do with what I originally trained. There's very few other residencies where you end up doing something that is not even a part of your training when you were a resident. It's weird, actually, that I'm not even doing for a living what I was trained to do as a resident. It's not like you would want an ER doctor that's not trained to do emergency medicine, or a general surgeon that's not trained to do general surgery, but that's how the science was in that era. It's just a strange waypoint in medicine that I hope someday somebody will write fondly about. But
is there any countries that are even more advanced than what we do here?
As far as the stroke medical stuff or the interventional component, or both? Or yeah, I would say right now 90% of probably, or more, 80-90% of the medical literature, as far as like aggressive medical literature for strokes, coming out of Europe and China and stuff like that. They're doing a ton of work with the stuff you and I were talking about earlier, which is all this biochemical blocking of this secondary apoptotic cascade and this secondary injury. It's real. And it's as real as like rheumatoid arthritis and stuff was before they had all these monoclonal antibodies that, turned that to nothing now. 25 years ago, people lost their incomes and their jobs and livelihoods because they couldn't walk with rheumatoid arthritis. And now they can go every 8 weeks, get an infusion and work normally because it's like a switch. They're turning off this TNF or tumor necrosis factor that triggers that inflammatory spark. But that drug didn't exist until a guy invented it in New York City at NYU. It's amazing, small things historically in medicine that have caused massive ripple effects in the treatment of disease process. And that story should be a movie. Somebody should do like a Lifetime movie about that guy. His name's Jan Vilcek, and he's this little old man that survived the Holocaust in Europe during World War II, and he moved with his wife to escape the Holocaust and ended up in New York City with like $200 in his wallet and showed up in New York City, and he went to work as like a janitor or something at NYU and worked his way up to becoming a very astute biochemical professor there. And he invented the anti-TNF antibodies that are the linchpin of all treatment of inflammatory disorders today. You know, IBD and rheumatoid arthritis and psoriasis and all the skin disorders that you see Cyndi Lauper on TV talking about and stuff. All those medications, that whole industry across the world, all are tied to this monoclonal antibody he created in that lab at NYU to just simply chelate up and stick to tumor necrosis factor, which is a signaling pathway to spark the inflammatory cascade. And this little guy there invented this antibody that changed 15 diseases. I've never met him. I've always wanted to meet him. I got a chance to get a letter from him once. I wrote him a letter and he actually answered me back. But little things in medicine cause a huge ripple effect. Huge ripple effect over time. Thanks, guys, for coming. Appreciate it.